Hello, everyone. I'm Laura Beauchamps. I'm an assistant professor at the Division of Infectious Diseases. And we really would like to thank quickly the opportunity for be speaking today with my fellow, who is Edgar Fernandez. Dr. Fernandez has shown from the beginning a great interest in LGBT health, especially transgender health. Changes that we're doing in our division, especially his interest in and his work that he has done with us implementing, helping us with the implementation science with a new clinic that we have, the Trans Prep Clinic. So he'll be talking about our efforts and giving you a big background for this vulnerable population. So thank you so much. And Edgar, Dr. Fernandez.
Thank you, Dr. Laura Beauchamps. So like Dr. Beauchamps was saying, my name is Edgar Fernandez. I'm one of the ID fellows here at UMJMH. Today, we're going to be talking about transgender medicine with a particular focus on PrEP or pre-exposure prophylaxis. So I just want to wish everybody first a happy Pride. So my interest in PrEP actually began in residency, where I focus a lot of my time on community outreach organizations and including PrEP. And implementing PrEP strategies within those organizations, amongst them being Equality Florida, World AIDS Museum, and Latino Salud, where I volunteer as a board member. So where some of you may be asking, why is this topic even relevant? So the transgender community is a marginalized community, and with that comes a difficult time maintaining steady housing, jobs, income, and unfortunately, many of them have to basically prostitute themselves in order to make ends meet. Okay, and with that comes a high risk of HIV and STIs and higher risk of illicit drug use. In addition, they're at very high risk of sexual assault, abuse, domestic violence, homicide, suicide, and mental health illness. This is a picture. Her name is Unikari. She is the first transgendered woman here in Miami-Dade County to be murdered in January of 2021. She actually lived in the same building as one of my co-fellows, and she was murdered by her husband. So screening for domestic violence is very important in this population as well. And for the IM residents and even attendings on your certification and recertification exams, now on the ABIM, you will be asked questions on transgendered health regarding screenings, as well as gender-affirming hormone therapies, as I just took mine this past year, and I did have a couple of questions on it. So going back to basics, what is the difference between gender identity and sexual orientation? So someone's gender identity is their internal sense of being male, female, or along the spectrum of gender fluidity. Someone's sexual orientation, however, is who they are sexually attracted to. And someone's gender expression is how they express themselves, how they comb their hair, how they put makeup, how they dress. So for example, if I were to say I was born male, I identify as female, am I attracted to men? I am a transgendered heterosexual female. However, if I was born male, I identify as male, I am attracted to men, I am a cisgendered homosexual male. I was born female, I identify as male, I am attracted to men, that is a transgendered homosexual male. So where do we get our guidelines from when it comes to transgender medicine? So there's two basic organizations. The most prominent one you'll see is the WPATH, of the World Professional Association for Transgendered Health. Also, there is Fenway up in Boston that we also get our guidelines from. In order for any transgendered patient to undergo any kind of transitioning, there are certain criteria they must meet. So oftentimes they'll need 2 letters of referral. Typically you'll see that from psychology or psychiatry because they need a diagnosis of gender dysphoria, but they don't necessarily need those specialties to get the letters from. Also, they need to have capacity to make decisions and consent to them like any other patient, have controlled comorbidities, diabetes, hypertension, etc. And the most important is that they must live in the gender to which they identify as for at least 12 months, undergoing 12 months of gender-affirming hormonal therapy. So when it comes to the hormones for transgender women, the most common ones you'll see will be PO estradiol. There's also the patch, including the intramuscular injections. The PO estradiol is the most common one you'll see, about 2 to 4 milligrams daily. You'll usually give patients up to 6 milligrams at times. And it really depends on the patient. Some patients respond very well to 2 milligrams. Some of them need a little bit higher boost in terms of dosing. The other drugs you'll see used commonly is spironolactone as well as Lupron. But spironolactone is one that you'll see quite often used. And when it comes to transgendered men, We're very familiar with the gel and the patches. Many of our patients don't really like them. It gets very messy. So most oftentimes what you'll see used is the intramuscular form of testosterone being injected either weekly or every 2 weeks. So what should you monitor in transgendered women when you're giving them estradiol? Again, typically you're going to want to monitor them every 3 months. And then once they reach the steady state that they're happy at, then you'll do it every biannually. And then the goal for treatment is basically to have someone's hormones, either testosterone, estradiol, match the gender to who they identify as. So for example, for transgender women, testosterone levels should be less than 50 and the estradiol level should be in the normal physiological range of 100 to 200. Also, you got to monitor if they're on spironolactone, electrolytes, blood pressure, and you got to also screen them for cancer, routine cancer screening. So remember, these patients oftentimes still have a prostate. So if it presents to you like maybe prostatic cancer, it's maybe something that you should screen for. Also, if they're over the age of 60 or at high risk of osteoporosis, getting a basic bone mineral density scan is also something that we do. When it comes to transgendered men, same thing. We do it every 3 months until they get a steady state and they're happy with the results. And typically, we'll measure the serum testosterone levels, and typically you want to range between 400 to 700. Okay, we'll monitor hemoglobin and hematocrit, monitor for osteoporosis, and again, you need to screen them for any kind of cancer. So if they have not had any kind of what we call bottom surgery, okay, and they still have cervical tissue, you should probably screen them for cervical cancer. In addition, if they haven't had any kind of breast reduction or mastectomy, basically, then you should also screen them for mammography with breast cancer. So what kind of surgeries do these patients undergo? So there's transfeminine confirmatory surgeries and transmasculine. When it comes to the transfeminine confirmatory surgeries, we have breast augmentation, okay, or mammoplasty. And then the bottom surgery is the layman's term we use, involves penectomy, orchiectomy, vaginoplasty, clitoroplasty, labiaplasty, urethroplasty. And then we have other surgeries like facial feminization procedures, liposuction, lipofilling, voice surgery, thyroid cartilage reduction, gluteal augmentation, etc. Just so you guys are aware, typically the average cost for these surgeries is well over $100,000 to $150,000. So patients who do not have insurance, oftentimes is a really big hurdle for them. In terms of transmasculine confirmatory surgeries, we have subcutaneous mastectomies that we typically do for top surgery. Bottom surgery involves hysterectomy, salpingo-oophorectomy, urethroplasty, phalloplasty, vaginectomy, scrotoplasty, implantation of testicular and erectile prosthesis, and then other types of surgeries like pectoral implants, liposuction, etc. The reason why I mentioned the pricing is, like I mentioned to you earlier, they have a very difficult time maintaining steady jobs and stable income. And unfortunately, many of them will prostitute themselves. With that comes the risk of HIV and other STIs. According to the CDC, over 42% of transgendered women are HIV positive, a majority of them being transgendered women of color, Black, African American, Hispanic, Latina X, and minority 17% being of white Caucasian ethnicity. So what can you offer your patients? I'm sure you guys have heard of PrEP, or pre-exposure prophylaxis. Currently, we have 2 drugs that are approved. We have Truvada, which is your tenofovir, disoproxil fumarate, emtricitabine combination. And then we have our Descovy, which is your TAF, tenofovir alafenamide formula drug. The actual study that actually got the drug approved, the first drug approved, which was Truvada, was the IPREC study, and it looked at MSM, including transgendered women who had anal receptive intercourse. And it led to the approval of, like I mentioned, Truvada in July of 2012. Shortly after that, we had the Discover trial, and the Discover trial looked at Descovy in terms of PrEP, and that led to the approval of the drug for PrEP in October of 2019, so fairly recently. So what is the major difference between both of these drugs? So the big thing to keep in mind is when you put these patients on PrEP, the level that reaches rectal tissue, in order to get an adequate concentration in rectal tissue, you need to wait about 7 days from starting the drug, and for vaginal tissues about 21 days. In addition, what you'll see is that Truvada actually has a 10-fold higher concentration than Descovy in rectal tissue. However, we do use Descovy because of the less associated nephrotoxicity and bone mineral issues that it may have. The reason why is that Descovy, or TAF for example, has basically reaches the has a higher concentration, in your PBMC cells, up to 7-fold higher than Truvada. PBMC cells are basically your natural killer cells, your CD4 helper cells, etc. In addition to that, TAF has a longer half-life compared to TDF. That allows for a dose reduction or a decreased concentration of the drug, leading to a decreased toxicity associated with the kidneys and the bone. So when it comes to transgender patients, there is often a misconception amongst this population that PrEP will affect the hormone levels. So they do not want to take PrEP, which is why it's a very big struggle to get them on it. So this was a study that was published in the Journal of Clinical Infectious Disease in August of 2020. And it basically looked at a very small population, about 24 to 25 transgendered men and women. And what it found was that PrEP did not affect hormone levels and the hormones did not affect the PrEP. However, this was actually recently published, presented rather, at the Conference of Retroviruses and Opportunistic Infections in March of 2021. And what they did was that they looked like, again, a very small population, and they looked at the hormone levels while patients were on PrEP. And if you notice here, on the top here, patients that were on PrEP and that were had estradiol, or transgender women that were on estradiol, when they were on PrEP, the estradiol level dropped to about 284 from 334, and the testosterone level also dropped from about 812 to 738. However, the drop was not clinically or statistically significant because it still was in the range that we want the patients to be in. Then in the same study, they looked at the effect of hormones on PrEP. And in the transgendered men population, testosterone was shown not to affect PrEP in any way. However, in the transgendered women who were basically undergoing, who were injecting estradiol as opposed to taking the PO form of the drug, they were shown to have a 42% reduction in both Truvada and anthracytidine levels. So what is a recommendation for transgendered women? So typically we tell them to start Truvada if they have a risk of osteoporosis or their GFR is less than 60. Again, we tell them to switch to Descovy. If GFR is less than 30, we typically do not recommend PrEP in this population or in any population. And then for transgendered men, this is where it kind of gets a little bit murky in the waters, because all the studies that we've had so far are basically on MSM and transgendered women. So we do not have a lot of evidence for transgendered men, but the recommendations right now are Truvada to give. However, if their GFR is less than 60, we typically defer PrEP use. And if they have a risk of osteoporosis, then it should be a conversation that the physician has with the patient, whether they have a risk or benefit for it. So when you start them on PrEP, what do you got to get? Basic HIV screening, STI screening as well. You want to look at their renal function, make sure their GFR is okay. Also, you want to screen for hepatitis B because we typically treat HBV with tenofovir. And then you also want to screen for pregnancy. And typically you'll give a 90-day supply, no refills, to make sure that the patients follow up with you in clinic to get, just to reevaluate how they're doing. So typically what you want to monitor is renal function again, big thing. And then you want to screen them again for HIV, STIs. And I think, in my opinion, the most important is counsel them on risk reduction behaviors, because we know that PrEP does not prevent other STIs like syphilis, chlamydia, and gonorrhea, which is a common misconception in the community. So in the South, in the United States, we have a difficult time implementing PrEP here and getting people on PrEP. So this is a study that looked at implementation strategies, and what they found was that pharmacy-based PrEP was very good. Telemedicine, which in times of COVID we've used a lot, has been very effective. Stigma reduction campaigns, and also increasing reimbursement for PrEP via expansion of Medicaid and the ACA. And then also linking them to PrEP when a patient tests positive on STI screening, getting them on PrEP when they test positive. Now, the CDC has certain prevention challenges when it comes to the transgender community. So racism, transphobia, homophobia, HIV stigma are very big issues. They have a difficult time reaching transgendered youth who are less likely to engage in HIV prevention and treatment. Also, there are certain disparities that need to be addressed other than the PrEP, which is more behavioral, biomedical, structural. And then I think, in my opinion, the most important one that I've seen so far is that patients who are not on hormones and want to be on hormones, they will not take PrEP before taking the hormone. So that is something that we're trying to do at the GenWell clinic, where we start them on hormones or continue them on hormones and get them on PrEP at the same time. And we've shown very good success so far with that. And this is actually another study that looks at PrEP in transgendered women and what we can do to help scale up PrEP in this community. So the most important one is basically engaging with communities, organizations. So what we did at the GenWell clinic is that we reached out to organizations in the community and even going to certain venues like nightclubs or bars and going to the patient themselves because there's a very big mistrust in the community for the medical system in general. So going out to them is probably the safest way and the safest bet to get them on PrEP. The other thing you want to do is we want to have more trans-inclusive research and marketing strategies for this community. And basically what we're doing right now is basically educating you healthcare providers on gender-affirming therapies and how to care for these patients. And then also we need guidelines to address basically increased uptake and adherence of PrEP, most notably in the transgendered women community. So like I mentioned, it's pretty much a multidisciplinary approach to care. It involves psychology, psychiatry, plastic surgery, urology, vascular surgery, infectious disease, primary care, endocrinology, and case management. So if you guys have any patients that you'd like to refer to us, we're located on Northwest 7th Avenue. This is our number. You could ask for Dr. Beauchamps, you could ask for Dr. Chung or myself, and we're more than happy to see your patients there and start them on gender-affirming therapy with their PrEP. Don't forget that this year Pride is in September, so come out and show your support to the community. Thank you, guys.
Thank you, Dr. Fernandez. Lots of important information that you provided us, and we're grateful for this timely and important grand rounds, especially during Pride Month, even more appropriate. Two quick questions I have, and we do have time, so thank you for being timely. You noted that one of the acceptances of PrEP was that they wouldn't start PrEP unless they got hormones. Is it just a mechanism for these people because they have a hard time getting the hormones, that if you give me A, I'll get B? Or is there some other relationship between the two?
Maybe I can ask, say something about that. I have seen that these patients actually like to negotiate, the start of PrEP with the hormones, right? So what we have seen in the past, in the last couple of years, is that if we find out a good regimen for hormones, we try to make sure that they can receive the hormones from one pharmacy, making sure that they have the lowest price, the lowest cost, and we can show that their levels are within physiological range and they feel good, they feel better, feminized or masculinized, then they are more willing to accept PrEP, and we will then make sure that they understand that there was no changes in their hormones. So we have found that the same happens with HIV, people living with HIV. So I think it's the same mechanisms. They would like to first be definitely on their hormones so that they can start on PrEP. And, this is the approach that we have seen. I think that in many cases, that's the way that we do it. But in other cases, they just start both together as well.
I see. And lastly, just a word of caution, because many endocrinologists have clinics full of cisgender individuals that have cisgender hormone replacement therapy, and normal ranges of these hormones are quite broad. And so to titrate to the patient feeling happy, I think may not be in their best interest. Yes, we want our patients to be happy, but we also need to be able to be aware of the various other components of the endocrine axis that may play a role in testosterone and estrogen replacement therapy, such as the gonadal hormones as well, and the side effects of influence on hematocrit and hemoglobin, as well as other cancer screening in patients that get these hormones. So just a word of caution that it's great to work in conjunction, collaboration with an endocrinologist in that regard.
Yes, definitely. Thank you for that. I think that it is a very good partner. I've worked with endocrinologists before, and I would love to see if we can get some collaboration here as well. We do you know, the questionnaires on cancer, family history, and we do give them the consent, and where it explains all of the side effects that could happen with these hormone replacement therapies, including thromboembolic event, you know, cardiovascular disease. So it just makes sure that they understand the importance of follow-up and monitoring of this level of the hormones. Mm-hmm.
Any other questions or comments from the audience? Please unmute yourself. Well, thank you very much. We appreciate that presentation. That was great. Okay, our next presenter is Dr. Khakoo, and who is going to introduce you?
Oh, I'm here.
Dr. Damas, wonderful. Thank you.
Hi, everyone. I'm Oriana Damas. I'm an assistant professor in the Division of GI, and it gives me great pleasure to introduce to you today my dear mentee, Dr. Nidah Khakoo, whom I've been working with for the past year. Dr. Nidah Khakoo graduated from Albany Medical College through a rigorous 7-year BS MD physician scientist program with a focus in basic science research. And since joining the internal medicine residency program, she's really worked extensively with gastroenterology and hepatology faculty alike in multiple research projects, and she's beloved by many of us. Her work has been published in top-tier journals, including the American Journal of Gastroenterology and Hepatology, and she's had the opportunity to present in several research forums, including just recently, actually the work that she'll be presenting to you today in Digestive Disease Week, which is really our largest GI conference held annually. So in addition to her strong research background, Nidah has been selected as, perhaps not surprisingly, Chief Medical Resident for the Internal Medicine Residency Program. So she's truly a rock star, and I'm very proud to be her mentor. And so without further ado, Dr. Khakoo.
Hi, thank you, Dr. Damas, for that wonderful introduction. I just want to make sure my screen is being shown and that everyone can hear me.
Yes.
Wonderful, thank you. So my name is Nidah, and I'm one of the new chief medical residents for the internal medicine program here at the University of Miami and Jackson Memorial Hospital. Today, I'll be presenting a talk on the development of a composite environmental score to predict age of onset and outcomes in IBD. To structure my talk, I've created some learning objectives. The first is to understand the role of various environmental risk factors on the pathogenesis of inflammatory bowel disease. I also want to review the hygiene hypothesis as it relates to the development of IBD. And finally, I want to present some data on the development of a composite environmental score to predict age of onset and outcomes in IBD. So let's go through our current understanding of IBD. So IBD affects nearly 3 million adults in the United States alone, and affects nearly double that incidence at a rate of 6 to 8 million worldwide. These numbers continue to increase at alarming rates, actually. If we take a look at this map that was published in 2017, you will see the incidence per 100,000 person years from 1990 to 2016 around the world. The red spots in North America, Northern Europe, and Australia are the current hotspots of high incidence of IBD. However, I want to draw your attention to the fact that there are new hotspots emerging. If you look not quite in red, but in orange, you will see countries in Northern Africa and India where the incidence of IBD seems to be increasing. Physicians and scientists alike have been trying to understand the pathogenesis of IBD in an attempt to find better treatment options and perhaps slow this rise in incidence. Although the exact pathogenesis of IBD remains unknown, part of the underlying mechanism is due to environmental exposures in those with underlying genetic predispositions. It seems that our understanding of environmental influences may play a crucial role in our overall understanding of IBD. A number of environmental risk factors known as exposomes have been explored in relationship to IBD disease outcomes. Some of these factors include smoking, dietary habits, water pollution, and medication use, including antibiotics. An element that is common between these identified risk factors for IBD is that they're all increasingly seen with Westernization. For example, some studies demonstrate that lower exposures to parasitic infections can alter the diversity and function of the gut microbiome, which we also know plays a crucial role in IBD. I want to pause here and put a little plug in about the gut microbiome. The gut microbiome is said to develop in the first year of life, and the microbiome can be changed in a potentially permanent manner based on whatever happens in infancy. The changes in the gut microbiome affect gastrointestinal immune response and ultimately can affect a child's risk for developing chronic autoimmune diseases, including IBD. I started to allude a bit to the hygiene hypothesis on the previous slide, but let's delve a little bit more into it. As developing countries have become more industrialized with improved sanitary conditions, patterns of childhood hygiene have changed, and thus was born the idea of the hygiene hypothesis. These improvements in hygiene include access to clean water, smaller family sizes and thus less crowding, non-contaminated food, and hygiene products, all of which have been hypothesized to result in decreased exposure to microbial agents. As such, these factors may contribute to dysbiosis, or an alteration in the balance of the quote-unquote good and bad intestinal bacteria. Bacterial diversity has been reported to be low in those patients with IBD. As with all great science, when a hypothesis is born, experiments soon follow. Several studies have looked at various proxy measures for microbial exposure in patients with IBD. Scientists have been trying to find a way to design a study that can really test this hypothesis and test environmental exposures, and it's not very easy. Some of the proxy factors that they've used include urban upbringing, hot water supply, separate bathrooms, all of which have been associated with IBD. Further, additional markers such as large family size and pet exposure have been noted to be protective in IBD, although the findings have been conflicting. All of this is to say that there is no single hygienic or environmental risk factor that shows a consistent association with IBD. So that brings me to the project that I've been working on for the last year or so under the guidance and mentorship of Dr. Oriana Damas and the IBD faculty here at the University of Miami. I'm going to spend the next 10 or so minutes highlighting the study and some key important findings. So as I've mentioned, I want to start with some aims. And as I've mentioned, there have been studies that have described environmental risk factors for the development of IBD, but very few studies have examined the effects of the environment on age of onset and IBD outcomes. And so the aim of our project was really twofold. The first was to carefully explore the relationship between the environment and the age of IBD onset. And the second was then to compile a composite risk score to assess the effects of environmental exposures on IBD onset and outcomes. So how did we do this? Well, first we administered an environmental survey to our adult IBD patients at our tertiary care referral center that queried 13 different exposures that you will see up on the screen. These exposures have been well described in epidemiological literature to be causal or protective in IBD. Some of those factors include being US born or foreign born, smoking at the time of diagnosis, delivery type, whether the patient was delivered via C-section or vaginal delivery, exposures to different pets, farms, parasites, antibiotics, and unpasteurized milk, to name a few of the exposures. The way that we did this is first we did a regression analysis that was performed separately in Hispanics and non-Hispanics to study the association between these exposures listed on the screen and the age of IBD onset. Regression coefficients and p-values were then used to perform a fixed effects meta-analysis across the ethnic groups. Significant predictor variables were then used to create an unweighted and weighted composite score by disease type, with a higher score reflecting an increased risk for developing IBD at a younger age. So a higher score meant that you had a higher risk of developing at a younger age. So let's go to some results. So first I wanted to talk a little bit about the demographics of our population. So we had about 1,600 patients with a mean age of 28.9 years, of whom 729 were Hispanic and 786 were female. The prevalence of each exposure is displayed on the screen. Along the y-axis, you'll see the prevalence in percentage, and the x-axis shows various lifetime risk exposures. Overall, a majority of our cohort had decreased housing density, defined as less than 8 people per household, and were US born. A minority of our patients had no pet contact, were smokers at the time of diagnosis, and were delivered via C-section. As you can see, many of our IBD patients already have environmental exposures of a population that is westernized. This slide highlights the aforementioned environmental exposures that did display a statistically significant association in the age of IBD onset. This was done through a regression analysis, and these are the conclusions. In the interest of time, I did not display the results of each regression, but I'm happy to discuss it if I have some time at the end. What we found was that significant variables for earlier ulcerative colitis onset included being US born, C-section delivery, fewer bathrooms in a home, decreased housing density defined as less than 8 people, being an ex-smoker at the time of diagnosis, and having no exposure to farms. For earlier Crohn's disease onset, risk factors included being US born, exposure to plastic water sources, fewer bathrooms, decreased housing density, and smoking at the time of diagnosis. One thing I want to note is that there seems to be a greater number of environmental variables that influenced ulcerative colitis onset in comparison to Crohn's disease onset. Next, we did a fixed effects meta-analysis, and only those variables that were significant and in the same direction of the effect were included in the final score computation. Highlighted variables on the slide represent statistical significance with a p-value of less than 0.05. This table has the exposures listed in the first column, followed by the meta-analyses by disease type in the second and third column. In the first column, you will see a risk exposure highlighted in red and bolded, and the reference each point was compared to in parentheses. The best way to understand this table is to actually walk through an example. So take the first exposure listed on the first column. So you see over here being US born for ulcerative colitis. If you look at the effect meta, it is negative, which indicates an inverse relationship to the exposure and the age of diagnosis. So the way to read this is that if you were US born on average, the onset for ulcerative colitis was 12 years prior to those that were foreign born. These highlighted variables were then used to create a weighted and unweighted composite score. This slide contains a figure that displays the computed composite scores and their significance. Crohn's disease is highlighted in green bars, and ulcerative colitis is highlighted in the blue bars. To start, note that our mean unweighted score were 3.5 out of a maximum of 6 for ulcerative colitis, and 2.7 out of a maximum of 5 for Crohn's disease. These unweighted scores were calculated through summation of each significant exposure. Mean weighted scores were 45.9 and 26.7 for ulcerative colitis and Crohn's disease, respectively. As you can see, the mean weighted score is higher in ulcerative colitis, and this is due to the effect size, which tells us the strength of the relationship between the environmental exposures and age. What I want to draw your attention to are the p-values on the top of each bar. The p-values describe the significance of the relationship of the score to age of IBD onset. You will see that for both weighted and unweighted scores, there were significant p-values for ulcerative colitis, but not for Crohn's disease. This suggests that our environmental score explains a greater amount of the variation in the age of UC onset, but not for Crohn's disease. Oop. Not done yet. So I want to discuss a couple of key takeaways from our project. So in this talk, I focused on the first bullet, which is that the environmental score that we presented explains a greater amount of variation in the age of ulcerative colitis onset in comparison to Crohn's disease. In addition, our studies have showed that weighted and non-weighted scores did not predict disease location, presence of extraintestinal manifestations, the likelihood of surgery or hospitalization, or the number of biologics needed. These were our secondary outcomes that we looked at. Another interesting observation we noted was that certain associations such as bottle feeding showed opposing effects in ethnic groups with IBD. For example, in non-Hispanics, bottle feeding was associated with an older age of IBD onset, but in Hispanics, bottle feeding was noted with a younger age, so you see the opposing effects in these groups. This led us to hypothesize that a combination of socioeconomic and cultural factors may be playing a role, and further investigation to understand these effects are underway. In terms of our future directions, our current studies are looking to validate this score in a large cohort of patients and to incorporate a polygenic risk score. To wrap up, environmental factors add a substantial level of complexity to the understanding of IBD pathogenesis. The key is to really translate environmental factors into mechanisms of IBD, and this is one of the first crucial steps in that direction. The presented study and its future directions aim at understanding significant environmental factors that are influencing emerging populations of IBD. Thank you so much for your time and attention, and I'd like to open the floor up for any questions.
Thank you, Dr. Khakoo. That was beautifully presented and very clearly presented. Your mentor has published quite a bit on diet and the influence that diet has, especially Western diets, on the incidence of Crohn's versus UC. And clearly that plays a significant role, and as does all these environmental factors. The question is, where is the final common denominator going to be? Is it going to be social determinants of health, which influence diet, which influence how many bathrooms you have in the house, or is it something else? And I guess, where are you in terms of, have you chosen the various SDOHs that might be involved in this?
I'm gonna have Dr. Damas answer it, actually.
Well, I think I can answer that, because I'm actually, Dr. Weiss, you hit the nail on the head. I'm looking at all sorts of things that independently can look like different projects or different areas of research altogether. But when you look at the whole picture about what really causes IBD and leads to worse outcomes, it really is a combination of these environmental factors that Nidah has been working on. That's why we also focused on IBD phenotype, not necessarily IBD risk. But also, what are some modifiable social determinants of health that we can identify, particularly in minorities, and use that to improve patient outcomes. So we're actually looking at these modifiable social determinants of health along with one of my mentors, Dr. Palacio. And we're right now in process of publication. And some of the things that we have found is that beyond, for example, financial insecurity and food insecurity, for example, there are some modifiable barriers that we could really, that are tangible and that could improve patient outcomes, like improving health literacy and improving discomfort filling out forms. And we found a correlation between those and also several outcomes. So, I think that it's looking at the whole picture, as you said, and Nidah has done just a phenomenal job really breaking down this metadata of our environmental factors. And I think this is really important work.
Agree. Any comments or questions from anyone on the?
I have one. So I thought this was an interesting talk, and as an immunologist, I couldn't help but notice the density of individuals in the household that seemed to play a role in whether somebody got inflammatory bowel disease earlier than later. And the question is whether that density is an immunologic one, giving disease to individuals and your ability to respond, which begs the next question is whether you put your child in early daycare may have an effect on whether somebody does or doesn't develop inflammatory bowel disease. Do you have any insight? I know it's sort of a random question, but I'd be interested to hear what your thinking is.
Well, I think that's a great question. I think we're all trying to understand what are exactly the factors. Is it genetics, or is it, an issue with the microbiome that perhaps together lead to an aberrant immune response, right? And I think that when it comes to the crowding history, I really do think that it has to do with changes in the microbiome that perhaps in the perfect genetic storm really culminate in these processes. And so, I think one of the key things here is, what can we tell families who have kids with, families with IBD who have kids, and they want to find modifiable things that are achievable and that they can do. And so far what we found is that, as Nidah highlighted, in ulcerative colitis, the environment really seems to play a bigger role, and perhaps mediated by the microbiome, which then results, I would stipulate, in problems with aberrant immune response and gut barrier interaction. So, I think that, to answer your question, I do think it's immune related, but I think there's that extra step of the microbiome involved in the process.
Thank you very much. Let's move on to our third and final speaker for this afternoon. Dr. Oringer will be introducing Dr. Grant.
Well, thank you very much. I'm Really happy to introduce Jelani Grant, who will be giving the presentation today. He is one of the 2021-2022 Chief Medical Residents at University of Miami Miller School of Medicine and is responsible for overseeing resident activities at Jackson Memorial Hospital. He's authored many peer-reviewed publications, several of which have been with me, and it's always been a great privilege of mine to work with Jelani. He's also presented at a number of national conferences. He's currently applying for a fellowship position in cardiovascular diseases with a special interest in academic preventive cardiology. He's now going to present a very interesting study, which we think is going to have some interesting implications for our medical center. Jelani?
Thank you, Dr. Oranger. Okay. Can you guys see my slide and hear me clearly?
Yes.
So thank you for the kind introduction, Dr. Oranger. My presentation today is focused on the importance of reporting incidental coronary artery calcification, also known as CAC or non-cardiac chest CTs. Thank you to Dr. Bokhari and Dr. Fishman from the radiology departments and Drs. Goldberger and Oranger for the mentorship on this project. My objectives for this presentation are to first, review the role of CAC and incidental CAC in ASCVD risk prediction. Secondly, we'll review the National Lipid Association scientific statement for the reporting of incidental CAC. Thirdly, present data on incidental CAC reporting patterns on chest CT scans done at the University of Miami Hospital. Then discuss template changes to enhance incidental CAC reporting. And lastly, provide updates on our initiative to implement a deep learning model that automates incidental CAC reporting. This figure is adapted from the 10-year association of CAC with ASCVD events from the multi-ethnic study of atherosclerosis, which was a landmark trial also known as the MESA study. There's a direct proportional relationship between CAC scores and major adverse clinical ASCVD events. Like blood pressure, the higher the CAC, the greater the risk. If you look at the line showing CAC equals 0, which is the lightest gray line on this figure, it's associated with a less than 5% 10-year risk, whereas CAC greater than 300 is associated with a greater than 20% risk over 10 years. This slide to me is very important because it drives home what the guidelines speak about in terms of primary prevention. The pooled cohort equations are used to estimate 10-year ASCVD risks. Statin therapy should be considered in select patients with borderline risk and all patients with intermediate ASCVD risk, usually between 5 to 19.9%. When a decision to start statin therapy is uncertain, CAC scoring should be used. A CAC score of 0 allows deferral of statin initiation and has a high number needed to treat, whereas this number lowers with increasing CAC. The decision is uncertain in 50% of the cases, and in this intermediate group, if the CAC is equal to 0. It's essentially a coin flip in deciding when to start statin therapy. This highlights the role of CAC scoring in re-stratifying patients. The greatest impediment to more widespread implementation of dedicated CAC scoring is that it's not covered by insurance payers. Patients pay out of pocket for it. There are additionally concerns regarding radiation exposure. The median radiation exposure for a CAC score is comparable and most times less than the radiation to the breast from a single digital mammography view. Mammography for breast cancer detection clearly reduces breast cancer detection, but perhaps a focus on reporting incidental CAC overcomes any potential limitations as thousands of non-cardiac CT scans of the chest are performed monthly with the opportunity to report CAC. Don Lloyd-Jones, in his 2019 paper published in the Journal of the American College of Cardiology, stated, the incidental finding of CAC on thoracic CT imaging done for other purposes does indicate the presence of coronary atherosclerosis. When possible, an Agatston unit CAC score should be reported for these incidental findings, or a qualitative indication of severity, meaning mild, moderate, heavy, or severe, should be provided. In general, findings of moderate or more CAC suggest a CAC score of at least 100 Agatston units. More recently, the National Lipid Association scientific statement on CAC scoring to guide preventive strategies for ASCVD risk reduction states, in adults found on the chest CT exam to have incidental, moderate, or severe CAC, initiation of statin therapy without dedicated CAC imaging is reasonable. In those found on chest CT exam not done for coronary calcium scoring to have incidental mild CAC, it's reasonable to obtain a dedicated CT scan for coronary calcium scoring to guide preventive treatment. This study by the National Lung Screening Trial sought to compare 3 CAC scoring methods to assess the risk of coronary artery disease and death in patients undergoing lung cancer screening. They enrolled approximately 1,600 patients undergoing low-dose CT scans using 3 scoring methods: the Agatston scoring method, the segmented vessel-specific scoring, and the overall visual assessment. By all 3 methods, increased CAC was associated with increased coronary artery disease events. However, visual assessment of CAC was comparable to Agatston unit scoring for incidental CAC. The authors concluded by using low-dose CT performed for lung cancer screening in older, heavy smokers, a simple visual assessment of CAC can be generated for risk assessment of coronary artery disease death and all-cause mortality. They also stated it was comparable to Agatston scoring and strongly associated with outcome. How easy is it to report incidental CAC visually? The answer is very easy. You don't have to be a radiologist. Simply looking at this slide, the far left pane, we see no calcification, that's none. If you see isolated flecks of coronary artery calcification within a segment, it's mild. If you see more CAC than can be considered mild, but less than severe, it's moderate. And if you see a continuous segment of CAC, it's severe. It's on this basis we sought to evaluate CAC reporting patterns at the University of Miami Hospital. We included 298 patients undergoing non-cardiac CTs of the chest and 41 patients undergoing lung cancer screening CTs during July of 2019. Using Dr. Fishman and his team, CAC was rescored in all patients by the visual assessment method. We recorded baseline characteristics, statin use, lab values, and CAC reporting patterns. Table 1 shows baseline characteristics. The left side of the table are the routine chest CTs groups, and the right side are those who underwent low-dose CTs for lung cancer screening purposes. The important take-home point from this slide is that in patients with moderate to severe CAC, they were most often older in the routine group, on average 70 years old. They were more likely to be male, and they were more likely to have no history of prior ASCVD, meaning an opportunity to intervene with primary prevention. More importantly, our study found that in the routine group, CAC was reported 60% of the time in the moderate group and 85.7% of the time in the severe group. As physicians, most time we focus immediately on the impression or conclusion of the report. And we found that moderate CAC was never mentioned in the conclusion, and severe CAC was mentioned 4.8% of the times. Lastly, the severity of CAC was never mentioned in the conclusion or impression of any report. Moving forward to the lung cancer screening group, moderate or severe CAC was always mentioned in the report, while CAC was reported in the summary 60% of the time for the moderate group and 75% of the time for the severe group. And the severity was mentioned 40% of the time in the moderate group and 50% of the time in the severe group. Simply put, the presence and severity of CAC mentioned in the impression was still suboptimal. What were the key observations of our study? First, as 89% of those who had moderate CAC and 56% of those who had severe CAC had no prior history of ASCVD, most patients with moderate to severe CAC were not receiving needed guideline-recommended preventive treatment with statins. Second, in the non-cardiac chest CT group, moderate or high-intensity statins were used in 33% of patients with moderate to severe CAC on visual reassessment. Lastly, in the lung cancer screening CT group, only 30% of patients with moderate to severe CAC were taking lipid-lowering medication, and of those, less than 50% were on a high-intensity statin. Why was CAC better reported in the lung cancer screening CT group than the non-contrast group? The main reason is that it's on the radiologist reporting template. All routine chest CT scans moving forward will mention incidental CAC as assessed by the visual method, meaning none, mild, moderate, and severe. And as I showed before, it's super easy to score. For patients with moderate or severe coronary calcification, clinicians would be guided to consider initiation of a moderate or high-intensity statin without necessarily obtaining a dedicated CAC score. For patients with mild coronary calcification, consider obtaining a CT scan for calcium scoring to guide statin therapy and decision-making. Transitioning to the near future, we have engaged the utilization of deep learning models to assist with reporting incidental CAC. Machine learning is a way to train computers to take a data set, create a model, and validate that model to produce clinically relevant data. A biotech company in California employed an algorithm developed at Stanford University to predict CAC from routine non-gated chest CTs. The algorithm trained on 447 paired non-gated chest CTs and gated coronary CTs from Stanford Healthcare and from the MESA study. The algorithm was then tested on an internal dataset composed of 88 paired studies from Stanford and MESA and 4 external datasets composed of 303 paired studies from 4 other institutions. They found that the deep learning model performed comparably to manual radiologist reporting. This slide represents 2 patients, patient A and patient B. The far left pane is the reference images. The second pane is how it would be envisioned by a radiologist. And the third, how it was read by a fully automated scoring. The deep learning model performed with a high sensitivity, specificity, positive predictive value throughout a range of CAC scores. It takes 3 seconds as opposed to 4 minutes taken by a radiologist to read. It also helps facilitate a rapid turnover and less work for our radiologist staff. The key implications of this study. Incidental CAC is not routinely reported at the University of Miami Hospital. Failure to report incidental CAC represents a missed opportunity to initiate guideline-directed preventive medical therapy. An initiative to routinely report the presence of CAC on non-cardiac chest CTs could represent an important quality improvement initiative at the University of Miami Hospital. Simply put, for moderate incidental CAC, a moderate or high-intensity statin should be considered, and for mild incidental CAC, a dedicated CAC score CT should be considered. I wanted to end by saying an ounce of prevention is worth a pound of cure, and thank you, and any questions?
Thank you, Dr. Grant, for another beautiful presentation. And thank you, Dr. Oringer, for your mentorship. You stole my line. Excellent. So were you involved at all in getting radiology to put that additional clause in their CT scans, or did they come to that conclusion on their own? If so, how do we forward this and advance it to the next step?
Sure. So I was definitely involved. We provided the references, the wording. I worked with one of the radiology residents, Dr. Bokhari and Dr. Fishman. We had weekly Zoom meetings. And once we were able to simplify it in a way that primary care physicians, cardiologists, and internal medicine physicians would be able to understand, we were able to develop the template, which should be going live very soon.
Thank you. Any other questions or comments? Well, I think we're ending our Grand Round season on a good note with great presentations. This concludes our Grand Round series for the year. We will begin again in the fall with the State of the Department address. And instead of binging on Netflix reruns, you may wish to consider in the lonely hours of the morning turning on your computer and viewing an old Grand Rounds. You never know what you may find. I wish you all a good summer. I'm sure we'll see each other many times before then. But thank you, and thanks to all our presenters and the mentors today for 3 excellent presentations. Everyone be well, be safe.